Welcome to the Talking HealthTech podcast. My name is Peter Birch. I'm joined by Lyndon, Goddard and Dr. Matt Vickers from Eucalyptus here in the Euc studio. Hey, gents, how you going?
Great, good.
Hey, Matt, it's been a little bit since we've done an episode of the Talking HealthTech podcast. I feel like it was this time last year that we sat down and had a chat here. So it's great to be able to connect again. A lot's happened in the Australian telehealth space over the last 12 months, and even leading up to that conversation had been a bit of a turbulent ride. I'd love to get your take on, I guess, how the telehealth landscape has evolved and changed over the last 12 months since we last caught up, because as we know in healthcare, there's a lot of different stakeholders. There's the consumer side, the clinicians, there's the regulatory piece. Walk me through how these last 12 months has been.
Yeah, it's been a crazy 12 months. I think last time we spoke, we were a few months into some operational changes off the back of the medical board guidelines around the conducting of telehealth. So we'd moved from a mostly asynchronous model to predominantly synchronous care, so doing phone calls, video calls with our patients, and that's completely sort of changed our model. But that's gone really well. It's sort of been certainly for the better, I think, from a number of ways. Our practitioners have loved it, patients have loved that. And we've continued to sort of build that out over time to a point where, we're doing quite a really high volume of those types of consultations. We've seen, I think, the market explode, particularly this year. A lot of sort of pop-up telehealth clinics appear out of nowhere. We've seen, this burgeoning market for instant medical certificates and things like that. We've seen the medical cannabis industry explode, and coming with that, the regulatory heat, and in many cases necessary, from what we've observed, and certainly the stories we've heard from patients in terms of what they've been experiencing. We've obviously seen the rise of a lot of AI, I think, as well, where that's now starting to intersect with the industry more broadly, will be an interesting sort of experiences as we see other telehealth organizations start to look at not just scribes, but I think if we start to see clinical decision support and where automations start to sort of come into these digital health flows, that'll be really interesting. But for us, personally, we had those changes to that model of care. We then had our accreditation from a clinical governance perspective. So we're now an accredited healthcare service since the start of this year with ACHS against those Equip 6 standards. We've continued to sort of build out our research function as well. So we've now had 14 or 15 papers now published, and that's starting to really show the fruits of what we've been building for a number of years in terms of that clinical governance and the quality and safety, the outcomes our patients are getting, and sort of our commitment around that transparency. So that has been internal publishing, and that's, to be clear, a start. We know that's not the best way of doing that, but we are working with, research partners, universities, etc., here in Australia, but also in the UK, on continuing to sort of publish that data to validate our program, prove what we've always said, and what we believe, that it is safe, effective, and high quality, and that patients can access it. And we've seen, patients are continually choosing to do that. And so there's been survey data that we've done, that we've had published and shown that patients really love this version of receiving, or this mechanism of receiving care. We know that there's huge variability in the sector, but we're also seeing, the numbers of telehealth usage is still quite high. A lot of patients still continue to use it, whether that's through their regular GP, whether it's their non-GP specialist, or whether they're going down the private direct-to-consumer pathway. It's still really popular. So, it's been a really exciting 12 months since we last spoke. A lot going on.
That's a lot going on. And when you talked about, the people still utilizing telehealth, we all kind of expected a bit of not a shakeout, but I guess the landscape continuing to evolve. And one thing, Lyndon, I've noticed, attending different industry events and just generally the engagement that Eucalyptus has, you've been pretty front and center in your role around the public policy side of things. And initially I was a little bit caught off guard because, Eucalyptus known for, being first to market with innovative models of care and doing things differently and pushing boundaries and all of that to deliver optimal patient care. The last thing I expected you to get really nerdy about was policy and governance and frameworks and everything. So talk me a little bit more through that side of things in terms of governance around telehealth over the last 12 months, about why it's taken your interest in particular.
Well, I mean, we're calling for more regulation, which is not something you usually hear from companies in a regulated space.
Yeah.
And so the thing we've been talking most about over the past 6 to 12 months has been some kind of accreditation or standards framework for telehealth platforms. And I think the starting point there is that you as a patient or a prospective patient, if you're walking into any health service in Australia, virtually or physically, you should be able to have a good understanding about the quality and the safety of that health service. And so where the gap exists currently is probably best illustrated by where the gaps don't exist for other types of health services. So if you walk into a hospital in Australia, you can assume that it has been accredited in some way. Someone has ticked some boxes. Someone has then reviewed that against certain baseline standards. And that assumption would be correct because, in fact, all hospitals and day clinics in Australia have to undergo some kind of accreditation. Similarly, for GP clinics, it's not compulsory, but most GP clinics have been accredited in some way, and that is how it should be. But by contrast, there is no mandatory or voluntary telehealth-specific set of minimum quality and safety standards for telehealth services in Australia. And we think, especially given the increasing popularity of telehealth services, that is a concerning gap and it should be remedied. And so there are various ways of doing that. You can do it by way of regulation or accreditation, sometimes both. So if you take the regulation route, then you're talking about legislation, provisions of medical board guidelines, for example. Those are then enforced in a reactive way, usually, in that the regulator or the institution in charge of the rules will really only check whether you've been complying with the rules if something goes wrong, if someone makes a complaint, or there's some kind of patient harm taking place. And the rules will usually be compulsory, and that's one method of checking compliance that exists. And then the alternative is accreditation, which is usually voluntary. Sometimes it's compulsory. But the important difference there is that it's proactive in that you, the health service, go to an external independent body to verify your compliance with the quality and safety standards that have been set out. They come and audit your processes, your clinical governance frameworks, whatever, and then they will decide whether you have complied with the standards or not. Either way, there should be some way for a patient to know, and then that then flows on to the way that regulators, governments, other members of the community perceive telehealth platforms. But at its core, the patients themselves should be able to have that information before they decide whether to undertake their healthcare with a telehealth service. So that's sort of the overall landscape. And then in terms of more specifically where the gap actually exists, a good way of illustrating it would be to imagine that you're walking into a GP consult. And so you're having a consult with your GP. The GP is going to decide whether to prescribe you some medication. We're talking about a bricks and mortar GP. And so there are different forms or different categories of regulation that apply to that consult. And it'll be a useful way of seeing where the gap currently exists for telehealth. So you might think about 3 different categories of types of regulation or standards in that consult. So you've got the doctor, the medication, and the clinical system. So for the doctor, you imagine the sorts of things that should be going through the doctor's head when they're deciding whether to prescribe your medication might be, am I taking good quality clinical notes of this interaction? Am I operating within my scope of experience? Am I making sure that I get the patient's consent before I decide to offer you a form of treatment? And as you'd expect, there are guidelines that cover that already. They're guidelines that apply to the doctor personally, and they already exist, whether or not the consultation is taking place in person or via telehealth. And so you'll see that in things like the medical board code of conduct or guidelines. That's fine. There's no gap there for telehealth. Then the second category, medications. So doctor decides whether to prescribe you a medication. questions there might be, is this medication approved by the TGA? Do I need to get an extra form of authorization in order to prescribe this particular medication? If it's going to be compounded, do I need to get additional consent from the patient? Those are all rules that already exist, and they're mostly regulated by the TGA. They also apply whether or not the consultation is in person or via telehealth. So no big gap there. Then the third category, the clinical system. So that's something that applies less to the doctor personally and more to the practice in which the GP operates. And so that contemplates things like, is there a good clinical governance framework? So is there a method of escalating clinical questions to more senior clinicians within the practice? Is there a good quality and secure database to store all of the patient records that have been recorded? Is there a method of auditing the consultations, checking whether patients have been misprescribed a medication? Have they been achieving the outcomes that they should be achieving? All that kind of thing. And so in a physical context, you will see things like that in the existing accreditation schemes that exist for hospitals and then similarly for GP clinics. But there is no equivalent for that category of rule for telehealth services. And that's where the gap is. And that the presence or absence of those rules and whether or not they're being complied with can have a real impact on the quality of the care and the safety of the care that the patients are receiving. So that's what we think needs to be resolved in terms of some kind of uniform government-endorsed set of quality and safety standards that apply specifically to telehealth. And the problem is, although there are some documents that exist that touch on the topic, there are so far no there is so far no specific accreditation document that has been created for the purpose of telehealth services specifically. And so it means, for example, that we could set up a telehealth service tomorrow and get Dr. Matt to do the prescribing, and there's no registration that has to take place as a telehealth service. There's no body that is accrediting the system that we're operating in, and we think that's a problem.
No, that makes sense. And I guess, one would hope that if, from a patient's point of view, a lot of those, quality checks and balances and things in that bricks and mortar setting, you kind of just assume those will take place because it's a place of trust that you can go for healthcare. So one could safely assume that those same kind of checks and balances would be there for a virtual setting. So I guess if nothing was broken, then you probably wouldn't be calling for stuff to be fixed. Matt, can you tell me like some examples of what this looks like in practice in the absence of these kinds of standards or this present gap that exists that you want to address? What does that look like? Or what does that mean that's happened over the past kind of 12 months or so?
Yeah, I think, anyone that's on social media probably has been inundated with the ads for any number of pop-up clinics selling products directly, sometimes in obvious clear breaches of TGA advertising regulations, including products that aren't readily available and shouldn't be. They're not regulated products like peptides and things like that are being imported from the US. I'm getting ads every day at the moment for a service that's offering modafinil, a very potentially dangerous stimulant medication that is just one click away on Facebook and things like that. So there's extremes to that end, and I think for the most part they seemingly are operating without any real consequence. They have been around for quite some time and are still advertising. So nothing seems to have occurred that's blocked them from doing that. And then I think even on the other end of the spectrum, it can just be where there are some an absence of some clinical governance elements like credentialing. What sort of practitioners are working on these platforms. We've seen, particularly from some of the clinician-led locuming services or support services, concerns about junior doctors, particularly those who have just had 1 year of experience post-med school. They receive their general registration and then are being courted by some companies to go and work online, unsupervised, doing general telehealth when they don't have the experience or expertise to be doing that. It's not appropriate. And certainly the environment that they're working within needs to be an appropriate training environment or with adequate supervision, hospital would be one of those, or an accredited training pathway like general practice training. Go and become a general practice registrar. But in fact, these doctors, they don't even have enough experience to even start general practice training. We wouldn't even let them become a registrar yet. Yet some of them are able to go and work on these clinics unsupervised because they've got a prescriber number. And I think that's kind of some of the gaps that, beyond accreditation schemes, the difference between a sort of face-to-face clinic is if a patient walks into a clinic and there's some clear and obvious deficiencies in just the physical nature of the clinic, what they can see, that's going to be obvious to a patient. Even the fact that most, general practice clinics, whilst they might not be accredited, in order to access Medicare rebates, there are certain things that have to be done. You have to, apply for a provider number, which they can't do if they've, to be able to access some of those rebates if they've just left the hospital system as a junior doctor. So, but when you have these sort of private systems where there's, you're not using those government related systems like Medicare or anything like that, they are a form of, I guess, regulation in a way, whilst not directly set up with that purpose. They still legitimize things. So if you, as Lyndon said, you can go and set up an online clinic, this afternoon. No one is looking over. Patients are held at a distance. You don't know. There's no requirements from a privacy or data security standpoint. Your health data could be, who knows where that's being hosted or what's being done with it by some of these companies. And there's none of that, not just clinical governance, but technical governance. What should you be doing? What should the EMR that they're using? What prescribing software are they using? How are they doing all of these things? There's no guidance there for people that are operating these services. And then sometimes these vulnerable junior doctors, who, we'll give them the benefit of the doubt and say for the most part, are vulnerable, don't understand the limitations of their training. This concept of unknown unknowns, they don't know what they don't know, don't understand how out of their depth they may be, or if other circumstances have forced them to sort of take these options. Some of these roles are very lucrative. And I understand why they might leave the hospital system to go and take them. But without the right clinical supervision, the right governance around them, it's a recipe for disaster.
Yeah. You got me thinking about the, from a patient's perspective, it's quite easy to, if you walked into a clinic and you looked and the physical surrounds indicated to you that it was not a quality operation, that can be much more obvious to a member of the general public compared to, it's a lot easier to spin up a flashy looking Facebook ad or something like that and that be the shop front, and then you don't actually know what's happening behind the scenes. So to have some kind of measure of that at least, or a bar, would be makes a lot of sense to me. I would hope that, I've been a big proponent that Australia should really be leading the way in terms of everything telehealth. We've got such a big country and people are spread out everywhere. We really should be leaning into the capability for a host of reasons. But sometimes I think it's always good for us to look overseas as well and see how other countries are kind of tackling this, because we're not the only country that does telehealth. Lyndon, from your perspective, are there other parts of the world that are approaching this in different ways? I know Matt touched on, you've been doing a fair bit of work in the UK and that caught my attention. Talk to me a little bit about what's happening there.
Yeah, it's interesting for us because we operate in 4 different countries, to see how different countries regulate telehealth differently and how relatively developed or undeveloped the telehealth industries are in each jurisdiction. And so we have a lot of experience in the UK, and the telehealth industry is bigger there. It's been around for longer. That's probably to be expected for a bigger country, but they also approach the regulation of telehealth differently to Australia, and we would say more rigorously and in a way that we can learn something from. So there are sort of 3 different levels of regulation or accreditation that exist in the UK. The first level is the level of the practitioner, the doctor or the pharmacist prescriber, which exists in the UK, or the nurse prescriber, the sort of professional rules that have relative equivalents in Australia. That part is pretty much the same. But then there's a second level, which is the regulation of the actual health services that are being provided. And so you can be a doctor, for example, in the UK, and you've got to be registered by the General Medical Council, which is like the medical board equivalent. But then if you're operating in a GP clinic, the health services that you and the other doctors in the GP clinic provide have to then be separately regulated by the CQC, the Care Quality Commission. And so that is a a position that doesn't really have an equivalent in Australia, and so they're a separate regulator that goes in and does audits of your practice. They'll come and look at your physical clinic if it's a physical clinic, and there's a telehealth equivalent as well. And then they will provide reports on their website, publicly available, of all of the clinics that they have audited, and will set out what their findings are, whether you've complied with their standards. And that is a level of transparency that we don't see in Australia either. But the concept that they have defined what the standards should be, at least in a clinical system category, as I mentioned earlier, and then independently gone and reviewed compliance with them, that's something that, it doesn't always work perfectly, but it's a level of rigor that doesn't have an equivalent in Australia. So that's an important difference. And then they have a third level of accreditation, or sort of voluntary best practice approach, which is embodied in this institution called NICE, which is the National Institute for Care Excellence. And so it also doesn't really have a full equivalent in Australia, but relevantly here, they review certain types of telehealth services. And so for us, our Juniper clinic, weight loss management clinic, exists in the UK. NICE earlier this year undertook a review of a lot of the digital weight management platforms in the UK, reviewed quite a large amount of evidence they'd provided in terms of the any patient adverse events, their prescribing practices, if they have any research backing their platforms, and then provided an endorsement of some of those services, including Juniper, which then is a signal to the NHS that NHS can then fund patients who use those services. So it's not a formal kind of accreditation or regulation as such, because it's not compulsory to go through the process. But the fact that this concept exists, that if you are doing a really good job beyond what the minimum standards are, you're doing a really good job of your health service, you might get endorsed by NICE, and that might then mean that you can be integrated with the NHS, which is itself a great marker of credibility and integrity.
Those could be some great, I guess, inspiration for Australia to kind of draw from. There are similarities between the UK health system and Australia, and there are differences as well. If, Matt, you had that regulatory magic wand and could, I guess, fix the standards in Australia, would you pull directly from how things look like in the UK? Would you borrow elements? What would this look like when it's applied to the Australian healthcare setting?
I think, as most people know, there's no shortage of issues with the NHS. So things aren't perfect. I think we've seen in the regulatory space where things can go well, particularly from our perspective with telehealth. And whilst it's potentially still not a perfect system, I think compared with the absence of no real system here, this reactionary system where really the only way things are going to be regulated or action will be taken against those who are doing wrong things in Australia is after someone's harmed. And I don't think that that's appropriate. That's the big concern, that a lot of these operations can continue for so long, and until actual harm kind of occurs, it seems like there's a lack of action. But the system of proactive regulation and the transparency around that, I think, is something that should be strived for. There's going to also need to be, that balance between incentives and the disincentives of around accreditation. If it's entirely voluntary in a private space, I don't think you'll have a huge uptake, and that's a challenge for whoever is implementing them. And then if someone is doing the accreditation or needing to provide the system that enforces it, that's certainly something to consider, whether it does need to be enforced as a mandatory thing, or is there an incentive there? Is there a future where telehealth MBS item numbers are not as restrictive as they currently are, provided you meet a certain set of standards? So if you're an accredited health service, you may, or patients may be able to access MBS rebates for services that you provide. If you're not, they're not available. So those sort of incentives may exist. Whereas in the UK, the system is you can't even operate the private D2C service without getting this accreditation done through the proactive regulation. So there's potentially even a middle ground there that's more achievable, particularly in the short term, that might address the concerns. I think our concerns stem from a worry that what standards are being drafted may be some time away. By that time, how much care is going to be delivered, and then how much potential harm is coming off the back of that in that time frame, if sort of things don't get better from what we've seen. But yeah, we're hopeful that it's one of the positives that can be taken out of the NHS. There's lots of things I think we're looking to take from the NHS, some good, some not so good. There's certainly a lot of learnings out of recent reports that have come from the UK government around their current issues. But this is one where I think it's really worth investigating and adopting some of those principles.
I want to come back to the point around, I guess, the sense of urgency around some of these standards and the need to implement some of them now. But Lyndon, I'd love to hear from you, given, I guess, the influence, like the scene that we've set and the influence from parts like the UK. Are there specific initiatives or things we can look out for, or like what Eucalyptus is working on? Because I know you're getting out there leading this conversation about the need for standards in telehealth. Are there what can we look forward to seeing from Eucalyptus this year and beyond in this space?
Well, as Matt said earlier, we've already got accredited to the Equip 6 standards, which is not specific to telehealth, but the closest document we can currently find in Australia that can accredit health services like ours that do exist in a telehealth context. And so we hope that that's a first point in terms of encouraging other telehealth services to find something that currently exists to get accredited. But the next big thing we want to do is to encourage the Australian Commission on Safety and Quality in Healthcare to progress their own work on producing a set of virtual care standards that we know is currently in development for the entire industry. In the meantime, we intend to publish our own document that reflects what we think should be the minimum standards of quality and safety for telehealth services in Australia, and we think that will be published pretty soon after this podcast is published. And so that will represent what we think should be the standard that all telehealth services in Australia should abide by. As Matt said, having a document sitting out there doesn't necessarily mean very much unless other platforms comply with it. And so there are options of voluntary or compulsory accreditation. Voluntary might be incentivized, as Matt said, from MBS rebates or other types of government incentives that already exist out there. But I think we'll continue to try to lead the conversation and show the importance of having an expectation of minimum standards in the telehealth sector.
Lastly, I think about, I guess for anything to get done, there needs to be motivation and a kind of burning platform or a driver, especially when it comes to something like regulatory and standards. And there's a lot of different priorities at the moment, particularly at a government level when it comes to healthcare, a lot of new initiatives, some exciting stuff coming out. But I guess sometimes these can always be competing priorities. If there was a message or a particular reason why we should be doing this now, not later, in terms of really kind of enforcing these minimum standards and requirements for telehealth, what would those key messages be? Because I guess, to your point as well, we want to kind of do this before someone gets harmed, and that sometimes, unfortunately, that's the way things progress through. But surely there are other ways for us to progress these things through without waiting for someone to get hurt.
Yeah, absolutely. I think it is a challenge because there are so many unknowns. A lot of the activity that's happening is occurring outside of existing healthcare systems. So it's really hard to see how many patients are actually accessing these services. It's something we're trying to address with some of the research we're looking at is how often are patients using it, and we're not the only ones. We're aware that possibly across some of the bigger organizations like ourselves and a few of the others, we're talking about potentially millions of consultations per year. And so whilst we know what our sort of safety data is and prescriber error rates, dispensing error rates and adverse event rates and things like that, when you start looking at that scale, it's inevitable that there will be some harm. I think that's likely to be the case. You can't deliver healthcare with zero harm. I think that's something that, all clinicians are aware of, but it's, what can we do about the environment around it that prevents that harm from occurring? I think it would be terrible that nothing happens until there is a level of or enough, serious harm for a regulator or someone to take notice. And certainly, we've seen that APRA have set up this sort of rapid response group within APRA, whether that's based off specific, volumes of complaints, whether it is a perceived concern about the industry. And that's not just about telehealth, but it's also looking at sort of the medicinal cannabis industry as well at the moment. Now, we're not involved with medicinal cannabis, but we have seen the reports and some of the action that's been taken by APRA recently. It would be a shame that the whole sector had to wait to get to that stage before something was done. And I don't think it's that hard to look, particularly as a clinician, and get a sense of where things might be going wrong across the landscape. Simple Google search will uncover some pretty bad practices. And if you spend enough time on social media following those Google searches generally, you're going to get inundated with some pretty ordinary stuff. So, it's pretty blatant in many cases. We're trying to do our best. We know there's a lot of the industry doing the right thing and providing a really important level of access and care for patients. But I would hope that we see some proactive action soon in trying to close the gaps between the best and the worst.
Well, Lyndon, Matt, I really appreciate you making the time to have a conversation. Look forward to checking in again probably in another 12 months and see how things have progressed. Thank you so much.
Thanks, Ben. Thanks.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.